zone, South Ethiopia, and my advisories, TMU. Universal health coverage means that all people have access to the full range of quality health service. One, they need to when and where they need, without financial hardship. So in Ethiopia, the government is trying to achieve a quality health service, but still the quality of this health service is under low performance, and the utilization is still also poor, and majority of the community are covered their health expenses from their out-of-pocket expenditure. So there is poor financial, there is high financial hardship. So objective of universal health coverage that every individual, regardless of their economic standing, gender, or any other distinguishing characteristics, has access to health service that both affordable and highly quality. So my motivation is that the price for health service in Ethiopia is very high. As literature shows that the per capita health expenditure in Ethiopia is $33 per individual per year, and the WHO standard was $6 per individual per year. So it's very low. So it's not, it's difficult to say it's affordable. And the quality of the health service in Ethiopia is also very poor. So this is the motivation. So for achieving universal health coverage in 2030 at the end of SDG, the government of Ethiopia introduces a financing mechanism of community-based health insurance. It is a voluntary enrollment basis, specifically targeted households in rural area, since 85% of the community in Ethiopia are living in rural area. So this community-based health insurance was introduced in Ethiopia as a pilot in 2011, and it was scaled up in 2015. So 80% of the districts in Ethiopia were involved in this CBHI. So globally, many countries have direct out-of-pocket payment made by household still accounts for the biggest portion of health financing, and in Ethiopia it accounts for 35% of the population covers their health expense from out-of-pocket. The most recent data reveals that approximately 2 million individuals are facing financial difficulties due to their health expense. 1.3 billion individuals globally are deprived of access to fundamental health service. Simultaneously, 100 million people are plugged into poverty as a result of out-of-pocket expense. So this is why the government of Ethiopia introduces community-based health insurance to save the citizens from out-of-pocket expenditure. So in Ethiopia, there are numerous investigations have been carried out in relation with CBHI, especially literatures from 2013. That means after the introduction of CBHI in Ethiopia, these are findings or literatures which are published on repeated journals, and I tried to review all of the papers starting from 2013 up to 2023. So majority of this study is focused on individual aspects such as utilization of health service, like impact of CBHI only on utilization of health service, or on impact of CBHI or risk protection, or impact of CBHI willingness to pay for the premium of CBHI. So majority of the studies, almost all the studies are focused on a single issue, but this study was focused on considering all issues: utilization, quality, and affordability. So the evidences from previous researches are somehow uncertain. This is mainly due to methodological constraint and a narrow geographic scope. Most of the study was conducted at district level or at Woreda level, but this study was conducted at zonal level. Woreda means in Ethiopia it's a district, and majority of the studies was over emphasis on pilot implementation which has restricted the ability to apply the finding more broadly. But this study aims to address these still existing research gaps. So from reviewing different literature, I tried to adapt this literature review, and there is a CBHI enrollment, and it will increase risk pooling, then increases there is enrollment of CBHI. So this increases risk pooling, and this risk pooling leads to financial risk protection. Again, this increase in risk pooling leads to increasing resource mobilization to health facilities. So this leads to increased access to health services, improving quality of health care. Again, enrollment in CBHI increases demand for health care, and also this reduces financial barriers. So these three issues, financial risk protection, increasing health access, and improving quality, are the issues of universal health coverage. So the study of this research focused on the impact of this, the impact of community-based health insurance on achieving universal health coverage. That means on improving financial risk protection, on increasing access to health coverage, and improving quality of health service. If a country achieves this universal health coverage, it will lead increases to health service utilization and health, and improves health outcomes like reduced maternal and child mortality. These are the research questions. The first one is, what's the impact of CBHI membership on health care utilization? The second research question is, how does CBHI membership affect financial risk protection? The third objective, or the third research question, is that what is the effect of CBHI on patient satisfaction? It's about quality, affordability, accessibility, and quality of care. The fourth one is, what are the key barriers and facilitators to CBHI implementation and long-term sustainability in Gamo zone in South Ethiopia? So the research strategy, the research study area is the Gamo zone, which is located in southern part of Ethiopia. And the study design, cross-sectional study by comparing health service utilization, expenditure pattern, and satisfaction between CBHI members and non-members. So the study also assesses how CBHI affects service delivery and service delivery of health facilities. So source population, the source population for this study are all household health source posts registered and not registered on CBHI scheme in Gamo zone currently will be considered as a source population. The study population, there are cases and controls. Cases are all randomly selected household health registered as beneficiary on CBHI currently, and paid premium in the past 12 months in selected district of Gamo zone. Okay, the sample size, the calculated sample size was 1,812, and this was round up, and I will consider 906 beneficiaries and 906 non-beneficiaries. The sampling procedure will be, this is a sampling frame. 30% of the districts from Gamo zone were selected for this study. It's based on WHO recommendation, and beneficiaries and non-beneficiaries will be distributed proportionally to each district. The data, the study will be used mixed method approach. Both primary and secondary data will be employed. Primary data will be collected through questionnaire, in-depth interview, and FGD. Secondary data will be considered from EDHIs and WHO and World Bank reports. This is the content of the questionnaire. The study variables, this study has the following variables. These are the dependent and independent variables. The independent variables are community-based health insurance. The dependent variables are healthcare access, financial protection, and patient satisfaction, and control variables, socio-economic factors, demographic and geographic factors will be considered. SPSS, STATA, and DP info will be used for data analysis. Poisson regression will be used for analyzing utilization of health service. That's my first objective. Multilinear mixed model will be used for analysis of out-of-pocket expenditure. The patient satisfaction will be analyzed using Likert scale method, and these are my implementation schedule plan, and these are the references that I used. Thank you. If you have comment, questions,